Case number 9. A 19-year-old female came with recurrent right lower quadrant pain. Laparoscopic appendectomy was done. Appendix is enlarged and erythematous and has a thickened wall. The appendix demonstrates transmural inflammation with lymphoid aggregates, aphthous ulcers, small surface erosions associated with neutrophilic infiltration, and deep fissuring ulcers extending into the submucosa and muscularis propria. Severe active inflammation of the mucosa, activity involving more than 50% of the mucosa with surface ulceration. The appendix demonstrates fissuring ulcers lined by active granulation tissue, fissuring ulcers extending into the submucosa and muscularis propria, pseudopolyps, severe active inflammation of the mucosa, and inflammatory expansion of the lamina propria with basal lymphoplasmacytosis. These photos demonstrate branching fissuring ulcers lined by active granulation tissue that is infected granulation tissue, pseudopolyps, severe active inflammation of the mucosa, activity involving more than 50% of the mucosa with surface ulceration, features of activity including neutrophilic inflammation with cryptitis, crypt abscess, and ulceration, and congested thickened blood vessels with hyaline thrombosis. These two images demonstrate transmural inflammation with lymphoid aggregates, muscular hypertrophy, a deep flask-shaped fissuring ulcer lined by active granulation tissue that is infected granulation tissue, severe active inflammation of the mucosa, and pseudopolyps. These two images demonstrate aphthous and deep fissuring ulcers lined by active granulation tissue that is infected granulation tissue, congested thickened blood vessels and hyaline thrombi, and severe active inflammation with cryptitis and crypt abscesses. These two images demonstrate mucosal ulcerations and erosions, focal cryptitis, architectural distortion, and inflammatory expansion of the lamina propria with basal lymphoplasmacytosis. These images show mucosal erosions and architectural distortion, severe active inflammation with cryptitis that is neutrophils attacking and within the lining epithelium of the crypts, and crypt abscesses that is collections of neutrophils within the crypts, inflammatory expansion of the lamina propria with basal lymphoplasmacytosis, and Paneth cell hyperplasia. These two images show architectural distortion active inflammation with cryptitis, neutrophils attacking and within the lining epithelium of the crypts, and crypt abscesses, collections of neutrophils within the crypts, inflammatory expansion of the lamina propria with plasma cell-rich chronic inflammation, and mitotic figures indicative of degeneration and regeneration activities. These images show architectural distortion, active inflammation with cryptitis, neutrophils attacking and within the lining epithelium of the crypts, crypt abscesses, collections of neutrophils within the crypts, inflammatory expansion of the lamina propria with plasma cell-rich chronic inflammatory infiltrate and basal lymphoplasmacytosis, and Paneth cell hyperplasia. The appendix demonstrates fissuring ulcers, severe active inflammation of the mucosa with surface ulceration, and scattered, well-formed, non-necrotizing, and sarcoid-like epithelioid granulomas. The appendix demonstrates mucosal ulceration, active inflammation with cryptitis and crypt abscesses, and scattered, well-formed, non-necrotizing, and sarcoid-like epithelioid granulomas. These two images demonstrate mucosal ulceration, active inflammation of the mucosa, expansion of the lamina propria by plasma cell-rich chronic inflammation, and scattered, well-formed, non-necrotizing, and sarcoid-like epithelioid granulomas. The serosa demonstrates poorly formed granulomas and multinucleated epithelioid giant cells, congested dilated blood vessels, and chronic and acute inflammatory cells. These two images demonstrate pseudopolyps, fissuring ulcers lined by active granulation tissue that is infected granulation tissue, severe active inflammation of the mucosa with cryptitis, crypt abscess, and ulceration, and scattered, well-formed, non-necrotizing, and sarcoid-like epithelioid granulomas. Okay, what is the diagnosis? Severely active chronic granulomatous appendicitis, consistent with appendiceal Crohn's disease. Differential diagnosis of granulomatous inflammation of appendix includes Crohn's disease, idiopathic granulomatous appendicitis, sarcoidosis, interval appendicitis, bacterial infections such as Yersinia and tuberculosis, and foreign body reaction, talc, and prior intra-abdominal procedures. Activity is usually graded: inactive, absence of neutrophils; mild activity involving less than 50% of the mucosa; moderate activity involving more than 50% of the mucosa; crypt abscesses often seen; severe activity, presence of surface ulceration or erosion. Let's talk about appendiceal Crohn's disease. General background. Crohn's disease is an idiopathic chronic inflammatory condition. It can involve any segment of the GI tract. Diagnostic criteria include segmental disease, transmural inflammation, noncaseating epithelioid granulomas, deep fissuring ulcers, ileal involvement. Appendiceal Crohn's disease is a rare disease. It has been well documented with an incidence of 0.2 to 0.55%. Appendiceal Crohn's disease could be isolated to the appendix or as a part of gastrointestinal Crohn's disease. Appendiceal Crohn's disease is usually found among young patients. However, it can occur at any age. The treatment of choice for appendiceal Crohn's disease is appendectomy, anti-inflammatory drugs, and immunosuppressants. The prognosis of appendiceal Crohn's disease seems to be much better than that of Crohn's disease arising in the small or large bowel. Thank you.